6 out of 10 of us have a long-term illness, a so-called chronic illness, something like asthma or diabetes. New research from the US suggests that whether we have a short-term or a long-term view of our illness greatly affects how well we do.
The way physicians are taught and the way we think about how to manage chronic conditions like diabetes, high cholesterol, high blood pressure is very different than the way that a lot of patients with those conditions are actually thinking about and managing their illness. In general, people are taking their daily prescribed medicines on average about 50% of the time. The problem is that essentially doctors are from Mars and patients are from Venus, that how physicians are taught to think about in their office how to best manage chronic illnesses like asthma, diabetes, high blood pressure, high cholesterol, is very different than the way a lot of patients with these conditions think about and manage their illness. As physicians, we're focused on these conditions as things that are there all the time, therefore you need to take medications every day, you need to adhere to a diet, do other sort of monitoring behaviors. But a lot of patients from the studies that we've done really have an acute episodic illness perception of things, and they're thinking about their asthma, their diabetes, the high cholesterol as something that they only have when they're feeling really bad. A lot of patients have what we call the no symptoms, no asthma belief, that they feel that their asthma is their attack when they're feeling sort of deathly breathless, but once that is passed, that their asthma is gone and then...
So it's out of sight and out of mind?
That's right, that people have sort of an out of sight, out of mind thinking about this. We found that if you ask patients how often they're taking their daily inhaled steroids, they're taking it about 70% of the time. We did a sub-study where we had electronic monitoring on people's inhalers, and that showed that people were using their inhalers on average of 50% of days were prescribed, and we're taking about a third total of the doses prescribed. So there's a big disconnect both between what physicians, what we want people to do, what people are saying they're due, and then when you more objectively monitor what they're actually doing. In diabetes, we found something similar.
Okay, so I'm a type 1, so that's insulin dependent. There's not much restrictions, you just got to monitor yourself.
Patients felt like they only had diabetes when their sugars were high, or that they could feel when their sugars are high, and so they were more than happy to take their medications when they were feeling bad or when their sugars were high, but they were not taking their medicines when they didn't either feel bad or when it wasn't high.
Just forgot, I guess. And there was a few instances when I woke up in the morning and was so low that I actually fell over and hit my head and had to be in hospital. So it's just, every time it happens, it's usually too much exercise, too much activity and not enough food.
We asked people what numbers they pick to be high. They pick much higher numbers than we as the medical community and the clinical guidelines recommend managing.
What's your target range?
Between 6.5 and 7.5 usually.
And what happens if you're outside that range?
If I'm low, which is quite common for me, I just make sure I have something sweet just to get it up a bit. Very rarely go high, but when I do, I just top up with the injection, just give myself a bolus of insulin.
What sort of reading means that you need to act urgently, that you're actually in a medical emergency?
A low reading, in the 2s, it's an emergency, you need food now or you're going to pass out. I have been at the point of when I've passed out, and I guess when you're high, if you're above 15, you need insulin straight away, so it gets dangerous.
And you don't think that patients are just in denial because they don't want to have a chronic illness?
Right, so this is, the denial is more than just a river sort of school of thought, and there may be a lot of that going on, but a lot of patients, I think, are sort of holding two paradoxical notions in their mind. I think most patients with a lot of these conditions understand that in the long term this is something they need to cope with, but connecting that with what they have to do today, with lunch or dinner or with their medications today seems to have different priorities than their longer term interests in sort of keeping things well controlled.
What about people who make an educated decision about not to accept a doctor's recommendations because the risk of side effects is too great?
So these are sort of the conscientious objectors. People need to understand that they are the ones who really have the power in managing and controlling their chronic illness. There are sort of two classes of people who are not adhering with their medications. They're, from a doctor's perspective, how you handle those two situations are very different. If people are sort of skippers because it's skipping their mind, you need to come up with a strategy of, put your medicine bottles on your sink by your toothbrush, and every morning when you brush your teeth, you're going to, brush your arteries and brush your lungs by taking your regular medication. For people who are not taking it because they're very worried about the side effects, they're very or don't understand the reason for taking them, then you really need to engage that person in a conversation to both bolster the rationale importance of why taking this every day actually is important to their overall health, as well as addressing some of their often well-founded concerns that medications can in fact have side effects and untoward consequences. And you want to acknowledge those because they're often real, but then put them into context, which often means that they are, in weighing the harms and benefits of medications, it's often still in their best interest to take them.